Hey guys, I just want to go ahead and put up a video kind of like we did when we talked about finding patients so that we have something to go on for the clinical performance exam. I actually conned one of my residents and one of the guys that works here in the ER starting med school next year to help me out with it. Basically what we're going to do is I want you to get familiar with the basic CPX or clinical performance exam. It's going to be in early April. What we're going to have is a situation where all of you guys go in, all 30-some pathologies that are available in the preceptor guide are potential to be tested for. That includes abdominal, thoracic, cardiopulmonary cases, neurologic, and musculoskeletal cases. In general, the format is going to be very similar for all cases. Is you're going to go in, you're going to follow everything you've learned in ICM1, ICM2 with regards to a normal exam, appropriate history-taking behavior, washing of hands, thorough focused history on this pathology, a thorough exam. And really, if you the main difference is going to be is that as opposed to ICM1 and ICM2, where your goal is just to do a complete history and complete physical, what we're going to try to do is a situation where you're actually trying to get information and direct yourself toward a diagnosis. So what you're going to do is you're going to do basically what you've been practicing with your preceptor groups, which is you're going to do a focused history of present illness. Now it's going to be a full 7-point HPI. After you go in, introduce yourself to the patient, ask their name, their age, and wash your hands. You're going to go in, do a full 7-point history of present illness. You're also going to be expected on the clinical performance exam, which is going to be a little bit different than what you've been used to in the previous courses. You're going to be expected to ask goal-directed questions. For example, if a patient has chest pain, it's going to be expected that you're going to ask them about key associated symptoms like shortness of breath, diaphoresis, and nausea. I think that as you go forward as a clinician, anytime you're evaluating someone with chest pain, you should think to ask, are you having shortness of breath? Where does the pain radiate? Are you having nausea? Did you break out into a sweat? You should consider whether or not they're having a cough, whether or not they have sputum production, hemoptysis, things like that. The patient with abdominal pain, you should pretty much ask about vomiting, about appetite. You should ask about relevance to food. You should ask about diarrhea, or whether they're moving their bowels, and then blood in the stools. These are just examples. Also fever. These are examples of things you would ask. For musculoskeletal complaints, you're going to ask about trauma. You're going to ask about overuse. You're going to ask about fever. Neurologic illnesses, you're going to ask invariably if you had an altered mental status or confusion, if you have numbness or weakness in certain areas, if you had associated headache, if you had dizziness. These are going to be expected for you whenever you're doing focused history of present illness. When I see patients in the emergency department, I don't go through a full 7-point HPI and not expect to get something toward a goal. I ask all the basic questions with regards to context, duration, onset, severity, associated symptoms, alleviating exacerbating factors, but I specifically ask them, have you had this before? Have you had a pathology X, which seems to be in the same general area that they're having symptoms? Have you been tested or treated for this problem before? Do you have the key associated symptoms, even if they say nothing is really going on with it? If they have chest pain, I am going to ask them if they have shortness of breath, regardless of whether they volunteer that to me. So basically, our goal in this course is to get you to where you can take a basic patient with one of the more routine pathologies, start from the beginning, and focus your physical exam and your history toward gathering that information. Along the way, not only will you be tested for your ability to do that, you're also going to be tested for your ability to be able to do a full history and a full physical exam. So your history of present illness, you're going to be expected basically and graded by the standardized patient on your ability to do certain key measures that have been put into the standardized patient scenario, and you're also going to be expected to fill out an essay form. So in just a moment, we're going to go through a simulated exam, and during that exam, I'm going to do a purposefully bad job on certain things so you can see where you would miss things. Other things I'm going to leave out are going to be very subtle things. And some of the stuff I'm just not going to do because I'm like you guys, I just forget, or it doesn't seem pertinent for that patient. But being focused on the patient's specific complaint, directing toward diagnosis, and then also being complete with examining and evaluating that area. As a general rule, if a patient has an abdominal complaint, you're going to be expected to do an abdominal exam, a complete abdominal exam. Even if every part of that abdominal exam is not on the checklist for the standardized patient, if you do the complete exam, your chance of missing something is going to go much less. For certain pathologies like chest pathologies, you're going to need to do a cardiac exam and vascular exam, you're also going to need to do pulmonary and thoracic exam, because these all fit into the differential diagnosis of something that causes chest pain. For pertinent abdominal issues, if they're having reflux, you expect to check the throat, maybe even the lymph nodes up here if you have a concern about malignancy or infection, and check the lymph nodes in the neck. For purposes of neurologic exam, you're going to expect to be able to do a full neurologic exam, and then a pertinent cardiovascular exam, for example, with strokes, syncopes, and seizures. It's where things where the cardiovascular portions may actually give you some of your neurologic symptoms. And this will all be discussed on that 7-point. What I've got here is a list, like the standardized patient will have, this one has 53 different items that you're supposed to be checked on. In a moment, I'm going to go through a stimulated encounter where I probably miss a significant percentage of this, and it's very easy to see how you'll rack up a lot of misses. I can tell you at the beginning, you're going to be expected to ask the patient's name, their age, an open-ended question. You're supposed to confirm what their chief complaint is, and then you go through your 7-point HPI, and then there are certain key factors. In this case, it's going to be an abdominal case, and you should confirm whether or not the patient volunteers it to you or not. Risk factors for abdominal pain that have to do with diet, that have to do with non-steroidal anti-inflammatory use, that have to do with alcohol use and cigarette smoking. And you also should be expected to ask whether the patient volunteers to you or not, about the vomiting, about the bowel habits, about blood in the stools or the emesis, about things like fever. So some of these things that fall outside of routine HPI, some of these things the patient is not going to volunteer to you, but you need to get in the practice of doing it. Also, you lose a point if you don't qualify exactly how much alcohol consumption the patient has. You're going to lose a point if you don't wash your hands before you see the patient. You're also going to, when you do an abdominal exam, lose points if you don't appropriately put the patient in the right position to be examined, and you're going to lose points if you don't do what they feel like was a full physical exam. But there are 50-some points right here on this that are going to come up. The next part is going to be afterwards. We'll go over this. There's going to be an essay part, which is the part you're going to fill out, and I'll show how we might fill this out for the standardized patient after the exam we're going to do. Sir?
Hello.
My name is Brian. I'm one of the emergency room doctors. Nice to meet you.
Nice to meet you.
What's your name?
Chris.
Chris what?
Bondic.
What's your last? How old are you, man?
I'm 23.
23? What's brought you into the hospital today?
I'm having pain up here in my abdomen area.
Oh, you are? How long?
Abdominal.
How long have you been having pain up there?
A few weeks now.
Okay. You have any? How bad's your pain on a scale of 1 to 10?
About a 9.
Okay. Are you throwing up with it?
Yes.
Any blood in your vomit?
No.
Okay. How about your stool? You moving your bowels okay?
Yeah.
Okay. Have you tried anything to make your pain better?
I've taken, well, since I thought it was heartburn, I was taking some Tums, antacids.
Does that help you any at all?
No.
Found anything that makes it worse?
Not that I know of.
Just keep your nose.
The pain it's always there.
Okay, that's too bad. Are you hurting? What kind of pain? How would you describe the pain that you're having?
Short pain, kind of a burning pain. That's why I thought it was maybe acid reflux or something. But
yeah,
it's just a chronic short pain.
I understand. So, I guess what other symptoms are you having with this? Are you having any? You told me you're having some vomiting. Are you having any other symptoms? Are you having any burning when you urinate or blood in your urine?
No.
Okay. Are you having any symptoms of pain in your chest or anything like that?
Yeah, right above my stomach, lower chest.
Okay. Are you having any trouble breathing?
No.
Okay. That sounds good. What kind of medical problems do you have?
None that I know of.
Okay. And do you take any medications every day?
No, I do not.
Okay. Are you allergic to any medicine?
Nope.
Okay. Do you have any medical problems that run in your family?
High cholesterol, high blood pressure.
Does anybody in your family have ulcers or anything like that?
Not that I'm aware of.
Okay. And what about you, for bad habits or anything? Do you smoke cigarettes?
I smoke about a pack a day.
Okay.
Drink a few cold ones here and
Drink
there.
a few cold ones, all right.
Yeah.
And do you any drug use?
No.
Okay. Anything else that we didn't talk about that you're worried about?
Yes, sir.
Okay, so I guess I'm gonna go ahead and examine you. Let me ask you a quick question, quick list of things. You had any problems with your eyes, your head, your throat, your skin, any of that kind of problem? Okay. No problems in your chest or belly other than what we talked about?
No.
Okay. I'm going to go ahead and examine you. Basically just kind of stick to your belly, which is the problem, seems to be bothering you. I'll probably go ahead and listen to your heart too, since it's going up in your chest. All right?
All right.
All right, I'm going to push on your abdomen here, each spot. And right here sore, is that where it hurts?
Yes.
Does it hurt when I let out on it?
Yes.
Okay, it does hurt just a little bit when I let out on it. Okay, I'm going to set you up here, check your back a little bit. Does it hurt back here in your back?
No.
Okay, all right. Okay, sir, well, I'm going to go ahead and review your files and try to get back to you on some information, okay? Is there anything else we can talk about?
No, sounds
All
good.
right, nice to meet you.
You too. Thank you.
Okay, Bruce.
So on a 53-point review here, it looks like that there are a few things that you lacked. During the patient's interview, you did ask the patient's name and appropriate identification. You did forget to wash your hands, and a few other questions about the quality of the pain. Also, going down the list, it looks like you may have forgot to ask a few things such as bleeding in the bowels, any anti-inflammatory or aspirin ingestion, as well as during alcohol consumption. He said he drank a few cold ones and did not specify the quantity and frequency of that. During the exam, also, he was sitting up at the time, was not laid back, and adequate exposure of his abdomen. You did some light palpation of his belly, but not really any deep palpation. Any other comments?
Well, basically what you just saw there was a rather poor example of how you should conduct a standardized patient exam. The reason I wanted to show that was I wanted you to identify some of the things that you'll be accounted off for if you don't do it. Off the top of my head, a lot of the things, obviously I'm going to forget, just like you guys are going to forget, no matter how much you're used to doing it and how much you study. One thing I can tell you is I didn't wash hands. I did not provide adequate exposure to the patient. I didn't actually lift up his shirt where you could see his abdomen. An abdominal exam should predominantly be done at 0 degrees, basically with him lying flat. I also did not ask him about some of the qualities and characteristics of his pain, the full 7-point history of present illness. I didn't ask him about blood in his stool. Blood in the stool and characterization of whether or not somebody's moving their bowels or having diarrhea is important with somebody with abdominal pain and diarrhea. Just like our narrator says here, I did not ask him a detailed history about his alcohol use. He has upper abdominal pain. I didn't ask him about whether the pain was worse or better with eating. I didn't ask him about whether or not he had a history of gallstones or pancreatitis, which is another cause of upper abdominal pain. I didn't palpate really a full abdominal exam. On your test, you'll be expected to do the full abdominal exam. Now, every point is not going to be necessarily something a standardized patient is going to check on or check off. However, I will say that you should be prepared to do the full abdominal exam. I only did light palpation in all 4 quadrants. I didn't do deep palpation in 4 quadrants. I didn't check for liver enlargement, splenic enlargement. I did not check the abdominal aorta. I did not do a very thorough abdominal exam. As you can tell, these are the kind of things you might miss. From the beginning, I didn't wash my hands. It's going to be very important whenever you take the standardized patient exam to always introduce yourself, ask their name and age, go ahead and ask them ask them if you have their chief complaint right. You should ask them what concerns they have and what they think may be going on with them. and you should stop at the end of the interview and summarize and make sure you have all the information as they have any questions. You also could maintain eye contact with the patient throughout the exam as best as possible. I'll go through the essay portion of the exam as well. Ultimately, I wanted you to understand that what's going to happen is whenever he gets done as a standardized patient, in this case we have someone who's filming and narrating, they're going to go through a checklist of 50 to 70 some points of history and physical examination. As you can tell how easy it is to rack up several missed points by things you don't think about: lying the patient flat, exposing the abdomen, washing your hands, asking the patient, going back through and summarizing the patient's information. I'm going to send out a approximately 7-page descriptor of some of the things I don't want you to forget about on the pathologies that we're going to cover. The pathologies that will be covered for the exam are going to be about 30 some that were listed in your initial syllabus, and we'll have a slight summarization of each of those and the things you don't want to miss on all those, although it's not going to be full. Now we'll switch off camera for just a second, and what we'll do is we'll go to a description of the checklist as well as the essay questions. I'd like to thank Bruce Kostelnik, one of the emergency residents, for helping me, and I'd like to thank Chris Bonnick, who's one of our nursing techs who's getting ready to start med school in the fall. Only a couple of medical people will get suckered into this kind of job. Okay guys, this is the second part of the essay portion of the clinical performance exam. There should be a similar sheet to this in your syllabus. In this situation, you're supposed to identify the chief complaint, and that's worth 10 points to you. In this specific instance, the patient's chief complaint was abdominal pain, or if you wanted to be more specific, epigastric abdominal pain. Then I want you to list your differential diagnosis. In order of likelihood to receive full credit, acceptable answers must be present on all lines. And so in this situation, I had a guy with upper abdominal pain. Now, I did a very poor history and physical on him. I did not get into the details of his drinking, non-steroidal anti-inflammatory use. I did not do a complete physical exam on him. So, for example, in this case, causes of epigastric abdominal pain might be, my number one diagnosis may be pancreatitis. And if I'd done a complete history, I would realize that this guy was a heavy drinker and that he had a family history of pancreatitis. But I did not ask him if he had a family history of pancreatitis, and the patient did not come out and volunteer it to me. I also did not ask him specifically about his alcohol use, which if we had known would have been very heavy. I think an alternative reasonable diagnosis, although I didn't ask about how it was affected by food, or go into things like his alcohol use, non-steroidal anti-inflammatory use, would be peptic ulcer disease. It does create an upper abdominal pain. Diagnosis number 3, this is a situation where you basically just want to put something reasonable. If you don't know exactly what it might be, I think that it's clear that pancreatitis and peptic ulcer disease would be our two most likely pathologies in this patient. I think the next one, a reasonable thought might be, for example, cholelithiasis, which would be gallbladder stones. Now, you'll notice right here, pancreatitis and cholelithiasis aren't on your list of 30-some diagnoses that we have in our preceptor guide and that you have in your syllabus. So these are not going to be ones that you're going to be expected to put down. The reason I'm using this is just to use a case separate from the ones that we're going to cover specifically in our simulated exams, so that there's not repetition. But basically, cholelithiasis is just the presence of symptomatic gallstones in the gallbladder, as opposed to cholecystitis, which usually represents an infection. Then it asks to identify specific findings that support your list of diagnosis and why the patient has the primary diagnosis. So in this situation, if I thought pancreatitis, if I'd taken a full history, I may place on there pancreatitis, and reasoning for pancreatitis is heavy alcohol use, past history of pancreatitis, which if I'd asked a full history on this patient and asked him specifically about pathologies I was concerned about, I would have found out. Family history of pancreatitis. And again, these are just for examples. This is not so you have a great learning situation on pancreatitis. And also, I might have put that the pain is worse with eating fatty foods. And worse with alcohol consumption. Now, as you might imagine, some of these same factors may be present in someone with peptic ulcer disease, but again, this is just for example. And then the least likely diagnosis, you must discuss them as well. So in this situation, let's discuss at least the two least likely. Peptic ulcer disease, I would say a burning epigastric pain in a smoker and drinker. And then for cholelithiasis, I may say intermittent upper abdominal pain would be my reasoning for considering that. If given a different circumstance, if the patient had had chest pain that was worse with breathing in and out, your answer might be that the primary diagnosis may be viral pleurisy, or based upon the factors of the exam, with a secondary concern of pneumothorax or a tertiary concern of something like a pulmonary embolism. And so that might be your three for this one. For a musculoskeletal case, it may be that a patient has some sort of ankle pain, and your primary thought would be osteoarthritis, and your secondary thought would be gouty arthritis, and your third thought might be rheumatoid arthritis or septic arthritis. And then based upon the history, you explain why you think number 1 is most likely, and then why you think number 2 and number 3 are reasonable alternatives. Based upon these, you will get credit based upon whether you have based these in the correct order, and they're for a total of 20 points. As you can see here, I did a pretty poor job on my bubble exam. Let's give myself about a 30. On my essay, we'll give myself a 45. So in this situation, I would have gotten a 75. So you kind of get an idea of how the exam is going to be conducted, and you're going to give an idea of how the exam is going to be graded by a bubble sheet filled out by the standardized patient worth 50 points, as well as an essay portion filled out by yourself for 50 points. Hey guys, so you basically see the general premise of our clinical performance exam. What I showed you was a pretty sloppy effort, both intentionally and unintentionally, to let you know the things we'll be expecting. There'll be anywhere from 50 to 70 points of history and physical that'll be on a checklist that you'll be expected to acquire that information or perform that part of the physical examination. The things that I would say are to get familiar with basic questions you should ask every patient with certain complaints. And don't wait just for the patient to give you that information. You know that if a patient has chest pain, you want to ask specifically, are you short of breath, not just wait for the patient to tell you. You know if a patient has abdominal pain, you want to ask about vomiting. You know that whenever you talk about your medications in an abdominal pain patient, you want to know about NSAIDs and aspirin and their social history, their drinking history, and be specific. You know when a breathing patient or a breathing difficulty patient, you're going to want to know about their smoking history, or in a vascular disease or chest pain type situation, you want to know about their smoking history and the details of their pack year history. Those are the things that you don't want to wait for the standardized patient to volunteer to you. You know when a patient who has a complicated illness, night sweats, weight loss, and complicated fevers or infections, you know you want to screen that patient for risk factors including exposure to HIV and tuberculosis. Keep those in mind on your checklist. That'll optimize, pardon me, that'll optimize the amount of the checklist questions you'll get. You also want to be familiar with the diagnoses in the essay portion of the answer and how to differentiate one symptom from the other. Obviously, knowing that someone has right-sided colicky pain would kind of bring you down more toward a kidney stone or gallbladder, but you want to obviously, whenever there's a pertinent, to do a Murphy's test examination on the patient with the abdominal right-sided flank pain to help differentiate that. You also want to check the costovertebral angle for tenderness when you're differentiating those. You want to ask about pertinent questions like the association of the pain with eating, like you might see in a gallbladder patient, or hematuria and urinary difficulty, or radiation to the genitals, like you might experience in a kidney stone patient. What I'm basically trying to say is, not only do you need to know the information from ICM-1 and ICM-2, but you need to build on that information to ask the appropriate questions and do the appropriate physical exam and to narrow it down. You're not going to have time to do a complete physical exam on everybody, but what you should do is going to every abdominal pain patient expecting to do the full abdominal exam, every neuro patient expecting to do a full neuro exam, musculoskeletal, obviously musculoskeletal exam, and cardio patient or breathing patient, a full chest, lung, and thorax exam. And then there are other situations where you may need to do more of the exam based on how it's pertinent. And I've included that some in your packet. If you guys have any questions or needs, you feel free to email me to discuss it further, and we'll try to make sure you have your questions answered. This will be a difficult test, but hopefully we'll be as transparent as possible to make sure that you know everything you can. And I think that most of you who have paid attention and have looked over this information will do very well once you've practiced up and thought about your information. Thanks.